Dr. Shulman named his own talk.
I did so.
Love it.
Yeah, I did like it. Yeah. Now I have an introduction that I want to do, and then we'll have Dr. Shulman come on. Then when he's finished, we'll have a video, which is really good. It's by our Calgary support group, and they sent it the last couple of days. And I thought, hey, this is perfect. So you guys are going to get the first showing of that. All right, Dr. Shulman.
Keep it short, keep it short.
Well, I want to tell you a story about Dr. Shulman. In 2007, Dr. Shulman came to us with an idea. He wanted to combine his love for cycling with fundraising for PARC. Marathon, Ontario is the halfway point from Vancouver to St. John's. And in July 2008, Dr. and Mrs. Shulman drove to Marathon to begin the trip. You can read the blog on our website. It's still there. Despite 18 days of rain, 2 flat tires, mosquitoes, and the creaky Newfoundland ferry, did I miss anything?
No, that's it.
Dr. Shulman made it to St. John's. Our slides, if you want to see our slides on it, we have a few on the computer. Dr. Shulman practices at the Wilderman Clinic in Thornhill, and he specializes in chronic pain, and he has done for many years. He also treats CRPS. He's treated many, many patients. Dr. Shulman is a fan of disabled sailing. So there's a table at the back. If you want to visit that table, he will take disabled people sailing in the summers. He's also a fan of cycling, marathons, and staying healthy. Please join me in welcoming Dr. Shulman.
All right. Now, am I obstructing anybody by standing here? Are we good to go? Okay. Everybody can hear? Fantastic. Okay. So, I just thought I'd mention a few topics. It's not what I feel is new or useful in CRPS. And it's a good thing I followed Andrea, because Andrea actually has the treatment for CRPS. I don't. Andrea's treatment is what actually gets people better. What my treatment does is perhaps give them pain relief in order to enable Andrea's treatment. Okay, that's basically the order of priorities. So the physiotherapy is more important than the medicines. Medicines are only helpful. Okay, so let's keep the priorities correct. Okay, so hot patches and beyond. But before I go into that, we'll talk about a bit about disabled sailing, right? Can you not hear?
The speaker's not.
Oh, okay. So, okay, I'll use the mic. Okay, fine. So hot patches and beyond. But I'm going to talk about disabled sailing first. Disabled sailing is easy, and everybody in this room can do it. And it's also quite inexpensive, by the way. It's not something you don't have to buy a boat, right? So I volunteer at the Queen's Quay Disabled Sailing, but there's a program, that's Queen's Quay, Toronto, but there's also a program in Hamilton and also in Bronte, and they're closer to here, if anybody is from the Niagara Peninsula. So by all means, think about it. I've got some brochures you can pick up. Now, so basically we're sailing this kind of boat, and this is called the Martin 16, and you see there are 2 sailors in each boat. The sailor in front is the member, the disabled member, and he or she is actually doing the sailing. So if you do come out for this, you will be learning to sail. No passengers, right? So the volunteer is in the back. If anybody is a passenger, it's the volunteer. So I get a free ride, right? Mm-hmm. So we teach the member to sail, and the volunteer is just there in case there's a problem, and also to hand out a few tips in this scenario. So you only really need one functional limb, in this case her arm, to sail. And she's actually, she was a member, but now she's a volunteer. She actually is a very good sailor. And she is the volunteer, so she'll be sitting in the back of the boat, and the member you see is the little girl in front, And so now the roles have been switched, and she's now a member, she's now a volunteer, and she can do everything she needs to do with one lid. So all of you, I think, can do this as well. It's a lot of fun. You get out on the water for a day, nice wind, usually a bit of sunshine, and the boats are provided as part of the membership. Membership's about $50 a year, not bad at all. When you compare the membership of a yacht club, which is in the tens of thousands, so $50 is not bad. And I think we do charge $10 or $15 for each time you go. So for $100, you get a pretty good season sailing in, and that's with a volunteer to teach you. And then you don't have to do anything. You don't have to regularly read the books. We have staff to do it. So if you're interested, pick up a brochure, call. Now there's no sailing right now, but the sailing season, well, at least the answering the phone season, starts in January, which is when we have the boat show. And if you want to come down the boat show, you'll see a lot more of us and other places as well that do disabled sailing. And then we start taking phone calls and requests through the website. So please think about that if you're interested for next summer. But don't call right away. Now, if you want us to contact you right away, by all means, give me your email before I leave, and then we will contact you right away. And you don't have to wait till the boat show. Okay? So that's one thing I can offer you. Okay, so we always have to have a disclosure, and I have no conflict of interest. I don't have any hidden agenda. I'm not making money in any way from this talk. And in fact, I'm not even building my practice because my practice is quite full. So we're just presenting this with no hidden agenda. Okay, so is there anybody on the fentanyl patch? Okay, right. I think you know already. I'll go over this briefly though, because it's of no interest if you're not on the patch. So the patch is now the most abused opiate, the most abused. So, okay, it's now the most abused opiate of all, more than methadone, more than OxyContin. And so, as a response to the abuse, which can be deadly, the government has put in various measures. And the first measure is that the patch has to be returned. An old patch has to be returned after it's been used before you get a new patch. Right? It's a patch for patch program. The second is that, and then the pharmacist will look at and count the patches, and they will look if there's any tampering, and if there is, then the doctor will be informed. So if you're on the patch or you intend to be on the patch, just remember, save your old patches and take them back to the pharmacy. That's the only real message. In the future, there may be a limit to how high a dose of patch you're allowed to receive. But we'll leave that for the future. Now the next is concerned with this problem, and this is obviously a fracture of the femur. See the hip joint is a Valsalva joint, and just down from that there's a bit of a bump on the femur, and there's a fracture right through it, right to the other side. So we want to talk about a medicine that's hopefully going to prevent this kind of fracture, and they're called, the class of medicine called bisphosphonates. Bisphosphonates. Anybody on a bisphosphonate? Nobody? I'm going to suggest you probably should be, and I'm going to give you evidence. Okay? Bisphosphonate. There it is there. That's a whole class of medication, and they were used initially to prevent bone loss with subsequent bone fragility and fracture in other diseases, osteoporosis and Paget's disease. But these bisphosphonates were found as a side effect, or a good effect, to reduce the pain of these other conditions. They actually reduce pain even though they weren't intended to do so. So this is about 20 years ago. It's a long time. And these drugs, and you know that there's bone loss in CRPS, right? As part of the dystrophy or atrophy of the limb, the bones get thin. And when they're thin, they tend to break. And so the bone fragility is a major problem. Now, you're not likely to use your affected limb for push-ups or whatever, but I mean, just even accidentally you could injure it, and then it might be subject to fracture, in which case that complicates everything, right? It's another trauma on top of the original trauma. The pain would really go through the roof. So one of our aims is to reduce the possibility of fracture, which means adding to the bone density, and bone density, hopefully, if high enough, will prevent fracture even if there's trauma.
Is this prescription or?
Yes, absolutely. So I'll tell you a bit about it, and then if you're not on it, you might consider it. I might be able to talk you into it. So the trials of bisphosphonate in CRPS are more than 20 years old, so it's not a new approach. It's been a bit slow to catch on. So pimidronate and alendronate were the first two that were studied. Alendronate is Fosamax. You might have heard of it if you're not already on it. Fosamax. It's taken once a week, easy to take, and builds up bone density. So one takes it usually in a sitting position and takes it with just a little bit of water and before breakfast, not with food. And then one sits up, does not lie down for a half hour, and then go about your business, have your breakfast, and do everything you want. It's once a week. It's not very good. So what's the evidence that will help you? Well, I'll cite two papers here. The first is Dirks, and here's what he said. In our opinion, the use of bisphosphonates can be recommended, however, for CRPS. Okay. However, which medication, which dose, and how long is not clear, and that remains the problem till today. Then the second paper, same year, 2012, is by Carolina, and these results provide conclusive evidence that use of bisphosphonates at appropriate doses is a treatment of choice for CRPS type 1. Pretty strong. Okay. So I tend to use alendronate, and that's pretty well my go-to drug, and I do it for pretty well all my patients with CRPS. In fact, it's said that the bisphosphonates may be the only medications that are specific to CRPS. In other words, lots of other treatments, but they haven't really been tested in CRPS, but the bisphosphonates have been and are found to be useful. The two new bisphosphonates that we're looking at now are nirindronate and zolindronate, and they are in studies, and one study is called the CREATE study, and that should be out in a year or two. I imagine the results will be similar to all the previous studies, but they may start to convince more doctors. You can jump in any time with questions. I don't mind a bit.
So is this on top of calcium and D3? Is it, if you're taking that, which
Yes.
I am,
Yeah.
does this also support, if you're taking that, you need bisphosphonates?
Right, so the question is, should we still take calcium and vitamin D3? And the answer is absolutely, because the bisphosphonate actually requires the calcium in your system. If there's no calcium in your system, bisphosphonates really don't work. So you do need to supplement calcium, or take a lot of dairy, which is always more fun. And so the dairy can provide you with about 1,000 milligrams a day of calcium, but you really need 1,500. So even people who do take a lot of dairy should probably have another 500 milligrams. If you don't take a lot of dairy, you might consider 1,000 milligrams of calcium every day. Same with vitamin D, D3. We only get it from the sun, and there's not a lot of sun most of the year in Canada, so I always recommend people take it. And the dose is 2,000 units a day. Now, if you really get a lot of sun, you live out in Florida or whatever, then you can just take 1,000. But most people should be taking 2,000 units a day of vitamin D3, 500 or 1,000 of calcium, and bisphosphonate. Okay. Yes.
So if you have an experienced contracture or atrophy, should you still be proactively taking bisphosphonates?
Yeah. Oh yes. Oh yes. Absolutely.
Because I have to, it's my leg, right? I'm actively using my leg. I haven't experienced any atrophy, muscle weakness, but I should still be.
I would.
Okay.
I mean, I can't say for sure. There's no proof. Now, what you could do is have a bone density study. The problem with bone density studies is if they hear that your left leg is hurting, they're going to take it on your right leg. See what I mean?
Yeah.
Because that's the protocol. If you talk them into taking on your left, fine, but they usually don't. They usually go. They don't usually go to
Not
the
a
place.
comparison.
I've never heard them doing that. So I think a bone density study is helpful, but it won't tell you about your specific limb. It'll tell you about bone density generally. So I can't really prove to you that you will have reduced bone density in your affected limb, but almost certainly yes, according to literature.
Is this a pill?
These are tablets, yes.
Okay.
Yeah. Take it sitting up, don't eat or drink anything for a half hour, because it can harm the esophagus if it sits in the esophagus. So you want it to go down or not. So you lie down, as soon as after you've taken it, it might sit in the esophagus, give you an ulcer. The other side effect is, after a long time, years and years of taking this, some patients have had problems with the jaw, and so we recommend a drug holiday after a few years, even after a year, a brief drug holiday. But that's all. It's very, very safe. Okay. Any other comments on bisphosphonates?
So would you take them, if you were a CPS person, would you take this the rest of your life, or?
CRPS? Yes, that's what I feel. But of course, it's a developing field. We don't know if in the future somebody will find a side effect we weren't expecting. These new studies, the CREATE study may tell us a lot more about it. All right, and the new bisphosphonate is the neurindronate, and that may be light years ahead of the old ones. I don't know. It's possible. Okay. Anybody else on bisphosphonate? Helen?
Dr. Shulman, the CREATE 1 study, you're probably aware of it, is that it's also in Canada?
It's
now?
recruiting, yes.
Yeah. So it's in Canada, US, and Australia.
Is that right? So do you know how to people can register for it?
Yes. They have to email me.
Okay.
I have the information in my computer.
Well, don't stop looking at your computer. We need you. Okay, so that's a study. If you wanted to undertake a study, that's fine. Okay. Anybody else about bisphosphonates? No? Great. Okay, so the next subject, I think you all know what it is. All right, there's a happy fellow with a blow-off.
Never seen an unhappy one.
Unless the cops are reading it.
Yeah, that.
If you ask me, that's in his backyard, right? I mean, that's not even, probably not legal, but you never know. Anyway, he's a happy fellow. So we're talking about marijuana. Okay, so marijuana comes from cannabis sativa, or there are other strains as well. But we'll talk about cannabis, and there's something called cannabinoids. Cannabinoids are anything that works like cannabis. So it's usually a synthetic, or at least a purified type of cannabis, and called cannabinoid. It's not quite cannabis, but it's pretty close. Okay, so cannabinoids. So what can you expect if you take cannabis or cannabinoids? Well, hopefully pain relief. That's the big one. That's what you hope for above all. And it seems to provide pain relief comparable to things like gabapentin and pregabalin and amitriptyline. But it varies from person to person. So some people may have very good relief, and some people say, oh, nothing happened, right? It's possible. Now, it's also good against nausea and vomiting. So it's an antiemetic, and it increases appetite, and that's how it was originally planned to be used for people with HIV/AIDS, wasting disease, when they couldn't keep on the weight, they had no appetite, they could lose weight, vomiting, and cannabis was very helpful for them. And it's actually a form of cannabinoid that's covered by the government just for this reason, and I'll tell you how to access that. The third thing it does is it's a sedative. Now, so it might help sleep, but unfortunately, it's such a sedative that it may make you high or stoned. Everybody knows about that. And the ingredient that does that in cannabis is THC, tetrahydrocannabinol. So you might want to avoid that, or at least keep the doses of that reasonable, so you won't get stoned.
You can just use CBD, right?
Well, you're way ahead. That's my third slide on.
Yeah, it's a lot of people who use CBD.
Well, it's hot, yeah, absolutely. Okay, so now it's proven helpful in the literature for nerve pain, neuropathic pain, in HIV/AIDS, and multiple sclerosis, and post-stroke pain, and many other neuropathic pains. It has been tested in CRPS specifically by, this is the only paper I'm aware of, if anybody knows any others, by Wilsey, and he looked at 12 patients, 6 of whom had CRPS, and he used 4 inhalations of vaporized cannabis, not smoked, vaporized. And he had a very low percentage of THC, which is 1.29. So that's so low that people would laugh at that today, but this study's a bit dated. And he found that it did help them. It helped them as much as their other anti-neuropathic pain medicines. So that's the one study I have specific to CRPS, but many, many studies. And there are hundreds of thousands of hits. If you Google cannabis and cannabinoids and pain, you'll get virtually hundreds of thousands of hits, right? So it's it's gaining popularity, and it's been studied in and out. So there are 3 forms that are available in Canada. One is cannabis itself. The other one is navalone, which is Sesamet, and that's a capsule. And that has a synthetic cannabinoid. So it's not the real deal, it's synthetic, but it works exactly the same as cannabis works.
I was on Navalone and I
Okay.
stopped it because it made me just so offside.
Okay.
Just smoking it or eating it was much better than the Navalone.
Okay, fair enough. So everybody has their preferences. Some people like Excessiment, some people like cannabis. But I'll just mention it because the nice thing about us is it's covered.
Yeah, it is.
It's covered by the government. But this is the medicine that was covered for HIV/AIDS about 20 years ago. And so, but they didn't put restrictions on it, so we can use it for anything we want, really. We can use it for pain of any sort of origin, or anti-nausea of any origin. So it's covered completely, no questions asked, and as far as I know, there's no plan not to cover it. Sativex is the second one, and that is an oral spray. So it's a spray, comes in a little aerosol delivery machine, and you just give it a shake and spray it. It goes in your mouth, has to fall on your tongue, somewhere in your mouth, your cheek, the tongue, wherever you like. You have to swallow it, that's fine too, it'll still work. But it works quicker if it lands in the mouth. And it is actually a combination of THC, and this is the new one, CBD. CBD is cannabidiol, and cannabidiol we'll talk more about because it actually reverses the stone of the THC. Okay, so if you put them in combination, you probably won't be stoned, yes.
So would you be able to take gabapentin and this, or?
Yes, absolutely. Because they work through different mechanisms. So we like things that work through different mechanisms because you can add them together so they don't conflict, right? So gabapentin, pregabalin, and amitriptyline if you like, and cannabis work well together. You can throw in Tylenol 3, you say ketamine. They all work through different mechanisms, so you can actually use them additively.
So is gabapentin sort of a nerve healer or something?
No. Unfortunately, it calms down the nerve, but nothing really heals. It calms it down, but as soon as you stop the gabapentin, the nerve will return to where it was before. It's just same really with all the drugs, unfortunately. But gabapentin and pregabalin work on certain receptors on the cell. Cannabinoids work on their own receptor, called the cannabinoid receptor, or there's a CR1 and CR2. So cannabinoid receptor. Opiates work on a different receptor, called the opioid receptor, the mu receptor. So all these things work separately, and they can all be used together and get them all to do their job on their respective receptors. And then you probably don't need the same high doses. So when you combine cannabis and Percocet, Percocet is much more effective. So you can lower the dose of your Percocet. So that's one way we're actually getting people to come down off their opioids is by giving cannabis. All right. It's a very useful medicine. Now for everybody, we'll talk about that in a minute. Okay, so those are the three forms: the Sesament, the capsule, the Sativex, the spray, and cannabis itself, which you vaporize.
Mention that Sativex is like $200 for it's not covered and it's expensive.
You're limited by the cost. But then again, cannabis is also costly. And it's also not covered by anybody that any drug company that I know, drug insurance. Okay, so let's look at THC and CBD, because when you come to order cannabis, if you wish, you have to specify to the producer how much of each you want. And there's certain rules. So both are active in providing pain relief and nausea relief, but the THC, remember, gives you the high or stone feeling and may cause a lot of drowsiness, where CBD doesn't. So it can reverse the high that you feel with the THC. But if you use just CBD, you probably won't get the same pain relief. So you really need a combination of the two, right? And we usually recommend a 1-to-1 ratio. 1-to-1 CBD, 1-to-1 THC. So you'll be ordering something like 7% THC, 7% CBD from the producer, and that's what you should probably start with, something in that range. Much higher than the paper I showed you, 1.29%. 7% is a lot higher, but again, you don't have to use much. 4 inhalations, maybe even 2 inhalations is all you need. So it can be quite powerful in small amounts, but just make sure you get the right mix, because the wrong mix might turn you off it entirely.
Does it matter if it's sativa or indica?
Well, the producers say it matters, but I don't know the difference, to be honest. So you have to ask the producers. They may say it matters, but there's nothing in the medical literature about which one you should choose. Okay? So, cannabis is legal in Canada, And the way it's legal is, oh, sorry, Helen.
Oh, I just wanted to mention that we had, on the back table, we have a list of the strains.
Good, okay. That's from one producer, that's Canada, right?
Yeah,
That's just one
one
producer.
producer.
So I'm carefully avoiding naming any particular producer because I have to be neutral. Okay? So, but there are 34 of them, and we'll talk about all the producers. So you have to first of all obtain from your doctor a medical document. The document says that you have a medical condition that can be treated with cannabis. That's the first requirement. Second thing is you have to look at the list of licensed producers, and they're all over Canada. They're in pretty well every province, and they all do their work through mail or courier. You can pay through the internet if you want to, but the product itself is shipped. So none of these producers have a store, and they're not allowed to have a store. So anybody who says, I've got a store, come on down, buy some legal cannabis, well, he's not telling the truth, right? So don't get involved with any stores or dispensaries. They can be shut down overnight because they're all illegal. Okay? Okay, now there's one other way you can get cannabis, and that is you can buy seeds from a licensed producer, and you can grow your own. Okay, that happy fellow at the front, at the beginning, he probably grew his own, and he's happy because it's much less expensive that way, but it's not easy to grow. It's not just like, tomato plant, right? First of all, you have to have the right number of plants. You're not allowed to grow anymore, and the police may inspect you. Secondly, it's a bit of an outlay. It's a bit of an expense to buy the equipment to grow it, and that expense you put up once, I suppose, and then you've got your grow out going. But it's not for everybody, and your plants may be ruined. Remember, and then your crop is gone, just like the farmers have a problem. And then you put out other expense, and you still have to buy it from licensed producers. So it doesn't work for everybody, but I know it works for some people. So it's up to you if you want to do it that way. That is legal. Okay. So licensed producers, as I say, there are 34 of them. They're all over Canada, and they're all very easy to talk to, and they're all have good, safe products. So they grow their cannabis under strict regulations. They have to know what the ratio is of THC and CBD, and they have to tell the customer what the ratio is. And as I said, you want a 1-to-1 ratio. Probably to start with, that's your ideal. And no pesticides are allowed in the growing process, and there's no mold growing on the cannabis, which is two things you might find on street cannabis, which I would not suggest at all. And all these producers have their own pricing arrangements, so that in other words, if you phone them up and you say, look, I can't work, I've got this one, they may take off 30% off the cost. That's happened. So you have to maybe dicker with them a little bit. They're all private enterprise, and they're all in competition. Okay, now, the people who answer the phone when you call the producer, they're usually a trained professional. It's usually often a registered nurse, and they will know what they're talking about. They can be trusted. So you can ask them, if you want to, you can reveal your diagnosis and reveal anything you want. You don't have to, of course, but if you want to get good advice, it might be best to say what you're looking for in the cannabis product, and then they help you to fit the product to the need. All right, so they're very good. The system actually works fairly well. It's all in your favor. And so when you phone the licensed producer, after you obtain the medical document from the doctor, you phone the licensed producer, and then I say you start with a 1-to-1 ratio of THC and CBD and go from there. And then the customer service, as I mentioned, are professionals. So how do you use it? Well, I mentioned a couple times vaporizing it. Vaporizing is very important. You don't really want to smoke it. Smoking is wasteful because most of it goes up in smoke, and smoke is harmful for your lungs. So I do not recommend smoke. You should buy a vaporizer. That's a one-time outlay. It doesn't cost that much, and it should last you your whole life, a couple $100. But then you have got a warranty. If you buy it from the licensed producer himself, you'll have a warranty. And they all seem to sell a vaporizer. And they're usually quite good. So if you drop it, you simply pick it up and it's still working. And if not, there should be a warranty on it. Vaporizers are usually, the ones I like are the volcanoes, which are about this big, look like a volcano. You put the marijuana on top, heat it up, and it gives off a vapor, which is like steam, basically. And you collect the steam, vapor in a bag, and then there's nothing that's going up in the air and being wasted, right? You've got the vapor in the bag, and you breathe in through the bag. And usually 2, 3, maybe 4 puffs is all you need, and that should last you about 4 hours. So it's very conservative. Then you can turn off your vaporizer, whatever's left on top you can vaporize later. So that's the best way to use it. It's least expensive. Now if you want to go with oral, you can do 2 things. You can buy the liquid or the tincture or the oils off the licensed producer, and you can use those. You can bake with it, you can just drop it on your tongue if you want. Marijuana mixes really well with fats, so if you're going to bake with anything that has margarine or butter, it's going to mix beautifully with margarine or butter. And then you've got whatever, brownies, cookies, whatever you want, and they'll last a while on the shelf, and you can just take a bite or have a whole cookie, depending on how much you need. Okay? But mark them carefully, because you don't want kids coming in the house saying, oh, let's have a cookie.
No, I'm laughing at eating more than one.
Sounds like you're not laughing at kids eating.
No.
Okay, that's fine. So, and you can order right from the producer, but it's more expensive, and you actually need more of it in your cookies than you would have in the vaporizer. So it's much more expensive that way. But certainly if you want to, if it's convenient, go ahead. But get an idea. But also order the 1-to-1 ratio, even for the oil. Even specify the ratio, CBD, THC for the oil. Same thing. Okay? So, who should not use cannabis, you probably won't get. Yeah, go ahead.
I know I've talked to you about this last month. You were saying about the oils and stuff like that, they don't act right away. The vaporizer acts right away within your system, whereas the oils take longer, right?
Exactly.
So
Yeah.
how much longer does it take? So if you take something in like a brownie or whatever, how long does it take for the time you consume it to the time it actually does something?
Right, that's a really good question. I should have covered that. So if you vaporize, it's going to work within 5-10 minutes, pretty much right away. If you put it in your cooking, then you're going to find, or even if you just put the oil on your tongue, it's going to take an hour, maybe 2. And the problem with that system is it's very variable. Some people, it takes less than an hour, and some people it doesn't work at all, even after 3 hours. So it's, the oral form is a bit unpredictable, so that's why I don't recommend you start with it. Start with a vaporizer, which works right away. Then you can kind of get an idea of what your mix is and how much you need. And then if you want to convert it to an oral form later, like the drops or the baking, then you get an idea of what you need, but probably have to double the amount you use. Okay, so I would not suggest using it orally to start with, to get a feel. Okay, great, thank you. Okay, so who can't use it and who shouldn't use it? Anybody with history of psychosis or family history of psychosis? And those who have trouble with their heart, and any little bit of heart stress is going to convert them over into an angina or a heart attack situation. They should not use marijuana, because it does increase the heart rate a little bit. Pregnant patients. And those under the age of 25 are not allowed under the Canadian guidelines just now to be given medical marijuana, because their incidence of psychosis is much higher than adults. Okay? And anybody with an active addiction disorder should not be given medical leave to use marijuana. Okay? That's for obvious reasons. Okay. So the risks, as you can take from the previous slide, risks for psychosis, cannabis addiction, depression. Remember, these are depressant drugs. Well, so is alcohol, really, but it's a depressant drug. It's not going to cheer you up, unless it reduces your pain, of course, or unless you want to get stoned and you like that sort of thing. But generally, it's a depressant. It depresses your whole system. It makes you kind of not want to do much, right? Lie there like a bum and not do much. So you could end up with poor schoolwork performance and what's called anti-motivational syndrome. So these are people who smoke the cannabis, sit on the couch, don't do anything, and wait for 4 hours and smoke it again, and that kind of thing. And that's what we don't like to see. If we see that, we don't continue the medical documents for using marijuana, because that's not what we want. We want people to be pain-free and up and active, right? So we have to watch for these things, motor vehicle accidents, because cannabis is a depressant and may impair your judgment. One thing about cannabis, though, I find that people, when they're on cannabis and they're a bit stoned, they know they're stoned. It's not like alcohol where you have no idea how drunk they are, right? They seem to know they're stoned and they say, well, I don't think I'll drive. But that's important, because if you're impaired for any reason, including using your cell phone, you mustn't drive, because you can be charged. Even if it's legal, you have to use your judgment. Okay? Now, carcinogenesis, which is cancer causing, is the same with cannabis as it is with cigarette smoke. So if you use enough of it, it will likely make you exposed to lung cancer. And then neurodevelopmental defects in children whose mothers smoked it during the pregnancy. So we don't approve it with pregnancy. I think nursing is probably okay. We don't know for sure, but nursing should be okay, but pregnancy definitely not. So that's it for cannabis. And anybody else?
Can I just ask a couple of questions?
Sure.
Of your patients, how many do you recommend cannabis for, the patients with CRPS that you deal with?
Right. Well, I mean, remember, I'm getting patients after they've had CRPS for years, and basically nothing else worked, because that's,
Right.
otherwise they wouldn't come to me. So I'm seeing patients really nothing else has worked. So I probably offer it to pretty much everybody, and I would say 50 or more percent take me up on the offer and order some, or else get the capsules or the spray.
So half of them?
I would say half of them look into it at least, and most of them probably keep on using it.
And is it for the pain or sleep problems or both, or is it generally?
Hopefully both. The problem with sleep is that a lot of people tell me that it makes them sedated and they want to lie there, but they actually don't fall into a sleep. Has anybody else have that
Did
situation?
that to me.
Now, right.
Yeah.
So it makes you kind of,
Hyper, but
or sometimes even hyper, right? So sometimes work paradoxically and make people agitated. And the other paradoxical reaction is, instead of calming down your stomach, it makes you throw up. So there's two paradoxical reactions. So everybody's individual. Those two problems, if they occurred with sesame, they'll likely occur with cannabis as well. And so I'd say that's probably not for you, to be honest. You can try cannabis still, but if it occurs with sesame, chances are, that's the whole class of drugs. So as I say, it may make you sedated, but actually not get into a good sleep, with stage 4 sleep and dream sleep, etc. Probably doesn't help you there.
Well, my question is that, like, with the gabapentin, with the naproxen, like, they're all they make you drowsy as it is. Like, when I'm on these drugs, if I stay for a minute, like, I just doze right off. Like, I have to keep moving on them. Then taking cannabis in combination, which you say you can take the gabapentin, I just think that might really.
Well, the nice thing about cannabis is you can change your mix. So if you're too drowsy on cannabis, you can take higher CBD and lower THC, or even no THC.
That's right.
There's strains of cannabis that are just CBD,
Okay.
and that's what's used in children who have epilepsy. It's just CBD, no THC. So there's lots of it. It's pretty flexible kind of medicine. You can change things and still usually get some results.
But the sleep takes higher CBD than THC,
Right.
and in sleep it's a lot better.
Excellent. Okay, sure.
And it's legal.
Sure. That's right. Absolutely. Yeah. Anything you want to try. That's what's good about this plant. Okay. Great. Any other questions about cannabis?
Can I just clarify? Sorry, I know it is. I think it is anyway, but carcinogenesis.
Yeah.
So you talk about people who smoke it. That's not
Yeah.
not a risk for people who are vaping, right?
Well,
Oh, we don't know.
probably not. Probably not. But we don't have figures on it yet. It just, there's no parallel between cannabis use, which is like, as I say, 4 puffs every 4 hours, and 2 packs a day of cigarettes. That's huge. So we don't know the figures for cannabis and lung cancer. But we suspect it's just from the smoke, yes, not from the vapor. You'll find vaporizing is really easy, especially when the vapor goes in the bag and it cools a little bit. You don't really feel it, or it feels like you're breathing steam. When you breathe cannabis smoke, then it really feels irritating, like you're breathing cigarette smoke or pollution. So there's a huge difference. So I suspect that will be reflected in the cancer figures, but we don't have cancer figures at the moment. Okay. Any more people want to tell me their experiences with cannabis or cannabinoids? I won't tell anybody. My lips are sealed.
I will just so that there's an opposite, because I take Napoleon all the time. Not all the time. I'm not on it now, but you know it. So it was great for me. So it really just took, yeah, it really depends on the person. And cannabis for me, I don't know whether I want to tell you the percentage of THC that's in that. It's pretty high anyway, a lot higher than 1%. And it only works sometimes. And it really depends on the mood you're in as well. And for me anyway. It definitely gives you lunch.
Oh gosh, yeah.
So yeah.
That doesn't help with the Lyrica too.
Yeah.
Waking.
So she thinks
Okay, and can I just ask you that you've got the CBD? High CBD, is it possible to ask you? That works for you? High CBD works for you?
Yes.
I know, but she knows exactly the.
No,
okay.
even like the doctor had said, get it higher in CBD and with less in THC, so you don't get that high, it relaxes you more.
But I get two kinds, so the one that gets you a little high, I think, before I go to bed.
But both of them are.
Sure, that's a good point. You can get two different mixes.
Yeah, because you get them from Metro, and the yellow and the blue, because they're different colors.
That's right.
So the yellow is for sunshine, so that's daytime, and the blue is for nighttime.
Oh, good.
And basically, it has helped him because with the burning and the sleep, whatever, that wakes him up at night. But he wasn't sleeping. He was lucky he slept 2 hours, and he'll be watching TV and he'll pass out. That's what it is, pass out, right?
So for 10 minutes and get up.
So he's only been on cannabis for what, 2-3 weeks at the most, and
Okay.
he's
And
helped.
you're
And
still-
he even managed to cut down on the Tramasat.
Oh, good.
Excellent. Not to tell us that.
Excellent. Excellent.
Because the only time I take medication,
Yeah, I'm not sure.
I'm mad, I don't like them. So maybe that's why we
Now
don't
he
help me, I
has to.
don't know.
What's the cost like though?
It's $90 a bottle.
Oh, you get the oil?
Yeah. Yeah,
Oh,
he
no,
tries
one of these is
Sesamat at first, but Sesamat didn't seem to help him at all.
Everybody's different. Good, okay, I hope you can find benefit from what you're using. Excellent.
But maybe you can try the vaporizer.
I've been told about the vaporizer, but I
Right.
should.
Vaporizer, I think you'll find it's a lot less expensive. You use your CBD as a dried plant, put it in a vaporizer, and breathe it in. It works quicker, more reliably, and it's usually a lot cheaper.
So it could be
Volcanoes
from
are
the same
expensive.
providers.
They're $800 for a volcano.
Maybe, yeah, it
Yeah.
could be, but it will last you all your life. And, you know, yeah, and I still think it's safer than everything.
Oh, absolutely. You can even get like pen vaporizers now, like the e-cigarettes. They
Have
have the
you
same
tried
idea.
those?
No, my brother-in-law does.
Right.
And he puts oil in it and he uses that as
Sure.
like
I don't know about those, I have no experience with them. I imagine that you're gonna drop them a couple of times, so, and I don't know how durable they are, but the volcano will last you all your life.
It would be a good way though to try it.
Yeah, sure.
Get
An
that
entry
vaporizer, the $50, you buy them just
Yeah.
about any swap meet. I use it occasionally,
Yeah.
recreationally, right? I generally smoke it, but the vaporizer, I didn't really right away realize I was getting anything from it. You don't see the smoke.
Yes.
And about 20 minutes later, I'm sitting there in a hotel and I realize I'm stoned. Right? I sat here now for 20 minutes thinking I'm getting nothing and now I'm completely gay. But for $50 opposed to the $800 vaporizer, you may find it works, you may not, you know what I mean? But I will tell you, even though you think it's not working, step away from it. First time, just take a break from it, you'll notice it's working.
So I think all the studies on first-time use are 4 inhalations, not more. And some people do fine with fewer, 1 or 2, but 4 would be your maximum the first time you use it. Okay. That's
So
it.
you
for-
pop it in, you do it into the bag and.
you can stay there too. It'll stay in the bag if you don't take enough hits that
And you
empties the
breathe it
bag.
in?
You can just yeah.
Sorry. The bag
And
is
it has a
most efficient.
mouthpiece. It's all hygienic.
It should have been.
No.
And then do that.
No, it's a mouthpiece and the bag is about this tall, and then it fills out, and you only need like less than half a gram, and it'll fill the entire bag. So you get a lot more for your buck with the papers.
The one I use is tiny. It's not a pet. It's a smaller one. And I did tons of research like you do, and it was rated a little bit higher than the Volcano, and it's like $150. It's so much cheaper, and it has like a glass pipe
Okay.
on top of it. There. It's so easy to use. So that's another. Yeah.
Yeah.
That's right.
Yeah,
Follow the
the higher
manufacturer's
the-
instructions. I believe heat should be about 185. If it's less than that, you're probably not getting all the things you want out of it. But if it's too high, of course, it'll start to smoke, which you don't want either. So you have to get experience.
Be a good cook.
Go ahead.
I said you have to be a good cook.
That's right. That's right. But don't test it out on your friends. Okay, good. So the final subject is the big one, special K. Okay. Who's had ketamine infusions?
Like that ketamine.
Oh, you've had other experiences with ketamine, have you? Who's had ketamine infusions for pain?
restrictions.
Nobody?
Wait,
You're waiting, okay. Okay, well, anyway, I'll go through it, and then you see if it's for you. It's not for everybody, as everything I say is not for everybody. But ketamine is especially, you know, you have to be very careful with ketamine. It's a potato. So here's ketamine. For CRPS, first of all, it's a general anesthetic. It's not a pain medicine. So it started out as and I used this in the 70s and 80s as an anesthetic. It's a very good anesthetic. The use for pain has really been discovered much more recently, again about 23 years ago. It all seemed to happen around 1990, right? So the use for pain is much more recent, and again, because it's a general anesthetic, it's got a different mechanism of action than all the others, and different than opiates, that is narcotics, different than cannabis, different than bisphosphonates. They all seem to have different aspects, you know, where they help you in the chain of your pain is quite different. So this is a totally different one. It has in common the anesthetic effect of something called dextromethorphan, which is a cough syrup, dextromethorphan. But you'd have to really overdose on dextromethorphan to get it to do anything like ketamine. Ketamine it does its job in actually normal use. The other thing that tends to work through that same mechanism is nitrous oxide. So if you've had an anesthetic and you've had nitrous oxide, you might feel better after the anesthetic, probably for the same reason. Even if it's not ketamine anesthetic, other anesthetics also use nitrous oxide. So it's a totally different mechanism of action, so it's additive. In other words, you can still use ketamine if you're using all the other things. You can probably cut down or reduce or even stop the other ones if you find ketamine more effective. Now, initially the use was ketamine coma, which means that we gave people enough to put them to sleep, because it's a general anesthetic. So we put them to sleep, and we had to put them on a ventilator because they didn't breathe on their own, and we had to put them in the intensive care unit. And even a short ketamine coma like that, we found that people had pain relief. Now, it wasn't initially used on CRPS. It was initially used on somebody who had shingles and posterior pain, post-shingles pain, and it worked quite well. And it only more recently became useful for CRPS, and it's become quite useful. The way we use it now is in not an anesthetic dose, but a sub-anesthetic dose, so a little bit less, so it doesn't put you to sleep. You end up being more or less awake, kind of sedated, but you would respond to somebody who said, "Hello, John, you know, how are you?" You'd answer. So it's a sub-anesthetic dose, usually used about 4 hours per day for 5 days in a row, and then that's it. That's your infusion, and then the effect starts sometime during that week and can last days, weeks, even months. And sometimes the pain relief is quite dramatic. It can bring pain down to maybe zero, and it can stay that way for weeks, sometimes months. Now, it's not forever, so we can't call it a cure, but it's probably the most effective thing we have for short term, and months is even kind of not midterm, not even short term. So it really can be quite effective, and sometimes we can even make it more effective by doing it a second time. So in other words, you do it once, and then it lasts 2 or 3 months, and then you do it again right away. And it seems to last even longer the second time, so it's quite nice in that respect. It's cumulative. What does it do? It reduces pain. Quite effective, especially neuropathic pain, and for some reason, selectively in CRPS. Some studies also showed improvement quality of life. People who did more, they got out, they went disabled sailing, they were able to go back to work in some cases. The movement disorders, the shakiness, and sometimes the twitching, and this and that stopped. And so it can be quite effective for a lot of things. And again, as I say, it tends to wear off, and then you do it again, and the outcome is actually even better the second time. But side effects, right? That's the kicker. So side effects, like any general anesthetic, nausea and vomiting, right? Like anything. And then the one that's typical of ketamine is dysphoria, opposite of euphoria, hallucinations, night terrors, and flashbacks. So if you look at that list, it sounds to me like a little bit like post-traumatic stress, okay? The flashbacks, night terrors. So people are sometimes quite afraid of ketamine. They have it once and they don't want to ever have it again or even hear the name because they might have a flashback to how badly they felt when they went ahead. Like that. This is how badly people feel. So the dreams, their hallucinations, or waking dreams, whatever I call them, they seem so real that people actually think they have it. They can be morbid and they can be bloody, right? So that's why I say it's not for everybody. If you have a tendency to take things seriously, be concerned about your dreams, think that your dreams are real, don't have ketamine because you definitely will feel ketamine dreams are real. Now we do make some attempt to modify these horrible side effects by using drugs like clonidine, benzos, which are like lorazepam, ativan, that kind of thing, diazepam, and antiemetics like Gravol. But they only do a part of a job. I mean, they might work in some people, but not in all. So some people, as they say, really are afraid of it, don't do well with it. And I did have one patient who went in it, and he seemed to be a stable guy. He went into our Western Hospital, they did look him over, they sent a psychologist, he was cleared. The very first time he had ketamine, he ripped out the IV and ran out. So he was very afraid of what he got. He did not like it, and he wouldn't even talk about it after. He couldn't go back for sure, and wouldn't even talk about it. So, as I say, it's not for everybody, but I think good screening before you do the ketamine infusion may weed out people who are likely to have that effect, but nobody can promise that. That's kind of what we think, but we don't know. So we really don't want to do people who are going to have that reaction, because that makes it worse. Yes?
I was just going to ask if they were aware of roughly how many people have these
reactions?
Yeah.
Reactions? I don't know. You'd have to ask them at Toronto Western, but it's a minimum because they do screen people. So, you know, all the people they see for ketamine, they probably screen out most of them, out half or so, as they're likely to have a problem, or else they haven't had everything else first. Like ketamine is really a last resort. So, if we send people to Toronto Western who haven't tried cannabis and haven't tried their bisphosphonates, and then they're sent back to try them. So, I hope that helps. You'd ask them, maybe they have numbers. But there's a problem, because of this problem with ketamine, it's not used lightly, and we don't use it in our clinic, and it's probably not used in very many standalone clinics, in other words, clinics outside a hospital, because we don't have the backup, the psychology, and the drugs, and that sort of thing. We don't have all that we can give to people to try and prevent a reaction. So, my feeling is not to go to a standalone clinic unless you want to take a bit of a chance. There are not that many that do it, and if they do it, they should go through all these steps before they offer it to a person. And I read that the CRPS, RSDRSA, HOPE in the States is recommending it in an emergency situation, which I think is the worst time to use it, because the person might go into emergency and be having horrible pain, and without the psychological counseling and without the other drugs being given at the same time, they're given a ketamine infusion, and I think that group is going to have a lot of people having a reaction. I can't believe they actually consider that method of administering it. I send people to Toronto Western Hospital, and it takes months before you can actually get your infusion.
So any pain, like I'm at St. Joe's Pain Clinic in Hamilton, he could refer me to Toronto West? Is that how that works?
Oh yes, doesn't he do it himself? No. At St. Joe's Hospital?
No, it's a clinic.
Oh.
Yeah, it's like, he said he wasn't able.
Okay, I see. Well, there's probably a place in Hamilton to do it as well. I mean, the master probably does it, I'm guessing. But if not, then Toronto Western. But they do have a bit of a backlog. You know, it takes months to get in, and they have to do all this testing, which takes even more time. So I think it's a long-term proposal. But the payoff is if it does work and you are a candidate and you don't reaction, it's exceptionally good. It's like pain relief. And you can go stop all your other medicines. Maybe worth it. And now we're back to sailing, it looks like. Okay, so that's my talk. Anybody have any other questions or any experiences they want to relate? Andrea?
How often are you using Lyrica or gabapentin or pregabalin, those kinds of medications?
Well, they're staples, sure. We use them pretty well from the beginning, and hopefully they help as well. But
They're pretty standard then?
there's
for-
there's that's almost the first thing you reach for, isn't it?
I find most people that I'm working with have been prescribed those, but you
Haven't?
did mention have been prescribed
Yeah.
those, so.
Yeah. It's pretty. I mean, they can prescribe. The first doctor who sees them, the plastic surgeon who treated their fracture, should start that. Helen.
The RSDSA protocol that we talked about, they were saying at the conference that if it was a low enough dose, that you probably wouldn't have those side effects. Is that true?
I don't know. I think with the lowest dose be effective though.
Yeah.
I mean, that's, I don't know the stats. I mean, but I think if they're going to do a protocol like that, it's experimental. And they should tell people you're an experiment.
Yeah.
And we're going to try you with a really low dose.
Yeah.
And have side effects, like green and sign on the dotted line. I don't think they can just do that as part of clinical treatment. Okay. And I personally, I might be tempted not to sign because I think my experience that it probably would cause problems.
I'm sorry,
It would probably cause problems to
Yes.
just do it on an emergency basis without all the checking beforehand and all the education that goes on. See a person in emergency just hooking up ketamine is, I think, going to end up in disaster. I could be wrong. I hope I'm wrong, but
Well, at the conference, they were making it sound like it was easy.
what do they have stats? So they have the numbers. I haven't read anything in literature, so I wouldn't do that until I see the numbers.
Well, Dr. Harvett would probably have the numbers,
Okay,
so
I'll speak to him.
maybe you could speak to him about it,
Sure.
because he's done the infusions for 15 years. And he was one of the ones who started it, started experimenting with it.
Okay, maybe wrong. Yes, sir.
Okay, sorry, so you're telling me my pain doctor could actually start a clinic and provide ketamine infusions if he had the approval for it?
Well, the approval's hard to get. You have to be an anesthesiologist.
He is, Dr. Champagne.
Oh, well, then he could, yes. He could apply for permission from the government, and he could probably do it in his office. But I think most anesthesiologists know about ketamine, and so probably say, I'm not going to touch that.
He's a researcher on it, that's what I was told that you can't get ketamine infusions in Canada.
Oh, sure.
That's about the impression I've had for how long now?
Well, they offer it at the hospital I'm being treated. I was offered a ketamine,
Which hospital?
St. Mike's.
Oh,
I think
Downtown,
that's where my
it's a
neurosurgeon is.
A teaching hospital in downtown, as you know,
Dr.
Toronto.
Schuster.
But what sort of threw me off is I am really prone to nausea. When I've had surgery, I can't even take a normal anus. I take propofol because I've been violently ill after I've done. It's like ridiculous, and because of from what I've seen online, at some of the conferences, the doctors who use ketamine say, well, we give them this, nausea is a real issue with ketamine. And I'm like, I can't even try that. I know I can't even take a regular anesthetic, so that's the only thing that, threw me off. But as I said, they think the pain block is the way to go right now there for me.
right, okay, I didn't talk about pain blocks. Maybe I don't think it's really time for that. Pain blocks. Generally speaking, it's like drugs. Pain blocks are temporary. They may work, they may not. But pain blocks can have side effects. So do drugs, really. But and we tend to reserve pain blocks for the beginning of this process. In other words, the first 6 months after you've had your CRPS developed. I generally don't get pain blocks after that 6 months, unless they've been really effective before the 6 months. So it's very unusual. I sometimes give lidocaine infusions. They're pretty good. You can use those anytime, and they don't have the side effects of ketamine, and they're done in their IV, but not in the affected arm. In the non-affected arm, start an IV, run in lidocaine, which is local anesthetic, and run it in overnight. That can be quite effective, and doesn't seem to matter how long after the start of the symptoms. But again, it's only temporary, maybe a week or maybe 2 weeks of some relief.
And the pain block works in what percentage of cases? I mean, just from your own anecdotal, I know.
I would say no more than 50%.
Yeah, I've had 2 and I never.
Yeah, I think it's you know, it's a toss of the coin, basically. You see, it depends on what's called sympathetically mediated pain. So that there's a certain subgroup of CRPs that sympathetic nerves are actually mediating the pain.
Okay.
That group does well with blocks. But I don't think they're more than 50%. And the longer you have it, the less numerous that group tends to be, and the more they jump over to the non-sympathetic mediated group. So in other words, the blocks become less effective the longer you have it.
So if someone like you present all the checklist of CRPS, that means the swelling, the stiffness of joints,
Right.
the discoloration of the hand, it's like I have all this. So would that generally be the sympathetic system reacting?
I find that I can't tell. Because I can take a person with all those symptoms, another person has fewer symptoms and signs, and yet the person who has fewer symptoms and signs seems to react better, and the person who had all the classical symptoms and signs. So it's really, it's not a science really, it's just often a trial and error. I hate to say it, but that's sometimes what we're left with. Okay. Hi.
Yeah, I did the IV lidocaine, it did nothing for me. It was like within 2 hours, it was like, what was that all about?
Once it wore off.
Why did I just waste a full hour laying on a bed because it did nothing? It was crazy.
It can help and it cannot.
Yeah.
Raise the temperature in my feet, that's what it did.
Oh, really?
Yeah, I wouldn't even register on the temperature tape, they were so cold. And then once you put the temperature tape on, it raised it to 36, 34.
Oh, that must be more comfortable or maybe not.
Well, only in the time, I couldn't feel anything from the waist down, but only for the time that until it wore off, and then it went right back to normal.
Well, it's something to try, but not
Absolutely.
Yeah.
Try it.
Okay, you guys were great. It's late and you're sitting here all day. I can't believe it. Way to go. Okay, Brian.
Oh boy. Now, I'm going to be very short since we've had 2 good speakers. I'd like to give them another round of applause